Hi, my name is Casey Posada, and I'm a registered nurse currently working at Sacred Heart Health on the Inland Coast in Florida. I work on the med-surg floor, and I'm also in pursuit of my Bachelor's of Science degree. For that degree, I'm taking an evidence-based practice class, and one of the assignments we were given was to look up a practice standard that can be changed and introduced into what we're doing now to prevent patient outcomes. So I chose to research hourly rounding and whether hourly rounding can reduce patient falls. Like I said, I'm a med-surg nurse, and as a med-surg nurse, patient falls are very important to us. We evaluate every patient every day on a fall risk scale and see whether they meet certain criteria to be on a higher watch. It's important because anytime a patient has a fall, they can have an injury, and if they have an injury, increased costs. Even without an injury, a lot of times we order extra x-rays and scans, and that costs money as well. And then if they have a broken bone or they break a hip, then they go to surgery, and all of these added costs break down into what they can pay their staff. So it's very important to us to prevent that patient injury, for one, and also to keep our costs down so that we can put that back into what we're doing as a hospital. My PICO question was for patients admitted in acute care setting. Is nurse-driven hourly rounding effective in decreasing the number of patient falls when compared to the standard care of rounding based on patient needs or assigned tasks per 1,000 patient days? The article I chose is titled, Can Rounding Reduce Patient Falls in Acute Care? An Integrative Literature Review. The article was published in Med-Surg Nursing Journal, and the Med-Surg Nursing Journal is published by the Academy of Medical Surgical Nurses. They aim to reach medical surgical nurses working in adult health and an acute care setting and help us to improve the way we're treating our patients and improve our patient outcomes. Darlene Hicks is the author. She has a Master's of Science in Nursing degree. She's also a registered nurse working as an instructor at the Breckenridge School of Nursing in High Point, North Carolina. Her research method, she used an integrative review, which included 14 studies. She classified all of her data into quantitative data, putting the numbers out there for everyone to see. Her independent variable was hourly rounding. Her dependent variable was the number of patient falls. And for her study, informed consent was not required because there's no patient identifiers involved. Inclusion criteria for her study included several things. She went to CINAHL, which is a large database of journal articles, and she entered the keywords hospital, fall prevention, and nursing hourly rounds. With that, she came back with over 2,000, almost 3,000 articles. And then she narrowed that down to the years 2009 to 2014, which keeps it relevant within the last 5 years of practice, put it in English language so she could understand what they were saying, and made sure that the articles were published so that they'd be from a viable source. For the results, 2 of the studies had unchanged results. One study had varied, so sometimes it decreased and sometimes it didn't. But 11 studies out of the 14 that were included showed decreased patient falls with nursing hourly rounding. Astounding. Specific findings, and some of the most astounding for me, was the Sicu-Moore et al. In 2014. They looked at 1 year rounding with 3 Ps, so pain, possessions, and potty, and they showed a 39% decrease in falls. They also showed a 36% decrease in call light usage, which, if any of y'all are nurses, you can understand how much that call light usage really affects your day. So if you can reduce that at all, it's definitely worth your time. Ford, in 2010, did a 3-week study with hourly rounding using the 4 Ps, pain, position, potty, and possession, and they reported no falls during that time. However, it was a very short period of time, so that needs to be evaluated further. Kessler, in 2012, did a 6-year study, or published a 6-year study. They used the 3 Ps, and they showed a decrease from 5.6 to 2.19 patient falls per 1,000 patient days, which is a huge drop. That's 50%. It's amazing. Saleh et al. In 2011 was on a stroke unit, and they used script rounding and they dropped from 25 patient falls to 4 patient falls within a 4-month period. The strengths of this article were the number of studies examined. She started out with 2,856 studies, and then narrowed that down to relevant studies and current studies, and came up with 14 very strong articles. Another strength is that it did show, the majority of them, 11 of them, that they were a huge decrease in falls. And not just a decrease by one fall, it was major numbers, 50% or 39%. That's a huge difference, especially in the lives of those patients. The articles were also recent, within the last 5 years, and they were relevant to our practice. A lot of hospitals employ an hourly rounding strategy, but it's even better when you look at, okay, this is an hourly rounding with a script, or this is an hourly rounding with a 4Ps. That's amazing evidence. And then the way she synthesized the information and kind of broke it all down for you, it just was very strong and very strong evidence. And then also the references are all there, so you can trace back all these articles and verify that information. So that was a big strength of the article. Some limitations were the falls that did not show a reduction also didn't really identify a reason why they didn't show that reduction in falls. So that's a little bit of a limitation there. Usually with research articles you say, okay, here was my strength and here's my weakness, but they didn't evaluate any of those limitations at all, which decreases the validity of their findings. I also feel like patient specifics needs to be examined. For example, we need to examine, okay, can hourly rounding decrease falls in the geriatric population? Can hourly rounding decrease falls in the stroke population? Can hourly rounding decrease falls in the acute and the disoriented patients, the ones that are confused and don't really know what's going on? Will that decrease their falls, or is that just something that we can't control? That's definitely something that needs to be examined. Varying time periods of the 14 studies were huge. So they ranged from 3 weeks to 6 years, and there's kind of a huge difference there. There was no standard amount of time to demonstrate whether in fact there was, decreased falls in a certain period of time. Also, another limitation is sustainability. Some of the studies showed a decrease at first. In fact, one specific study showed a decrease at first in numbers and then a rise. So it kind of makes you wonder, okay, did the nurses get tired of doing this hourly rounding? Were the managers enforcing it? Were they, following up with it? Or did it just kind of fall to the wayside? That's something that needs to be evaluated as well. And then some of the studies didn't exactly spell out their method for hourly rounding. They would say that they just did hourly rounding, but does that mean they're doing hourly rounding with a purpose? Or they step in the room, say hi, and leave every hour? It wasn't really specific. The ones that were strong were the ones that did say, I'm using the 4Ps, or here's my script. Those were very strong. But since some of them didn't evaluate that or didn't list that, it is one of the limitations of the study. How this can be applied to practice. Well, the largest number of reported adverse events is patient falls. So it's huge if we can reduce that number. Then it might not be the largest number of adverse events. It's also the second most frequent cause of patient harm. That's a huge thing as well. Like, if we can reduce patient harm, we as nurses are there to better the lives of our patients, not hinder them and not make them worse. It just feels horrible when you have a patient in the hospital and they're there for dehydration and then they get dizzy, fall down, and break a hip, and then they're there for a whole other reason. It increases their length of stay, and it increases their cost. And also their satisfaction with the experience. If I go to a hospital and break my hip, I'm not going to exactly want to go back there. And the cost is monumental. So in 2009, we were looking at a $19 billion expenditure just for patient falls alone throughout the country. They're estimating that by 2020, we'll have a $54 billion cost from patient falls alone. That's $4,200 per patient. That's a huge amount of number. And most of our patients, especially at Sacred Heart, because we're a charity hospital, they don't have the money, so that cost falls back on the hospital, and then you lose your ability to serve more charity cases, and also we lose our ability to pay our staff, and that's a huge thing as well. You can also, one of the studies, like I said, showed a decreased call usage of 36%. That's huge in the life of a nurse. When your phone goes off, it completely will mess up whatever running tasks you have in your head. So it's a huge thing if we can decrease that. It also decreases the stress on our technicians that are, running around and doing the potty breaks for us and helping the patients get what they need. And I have found in my own practice that when I do hourly rounding with purpose or with the 4P, I don't have as many call-out usage. And then when I need help, my technicians are available to me because they're not running around chasing their tail all day. It's difficult to apply this to practice because of many nurse-patient ratios. I'm lucky where I'm at. We've got a 5-to-1 ratio, which is a beautiful thing. But many hospitals have 6 to 7 patients for every one nurse. And when it takes 10 minutes in each room, it's impossible to get to every room every hour. You wouldn't have a break. You wouldn't be able to drink, get water, go pee. So it's a huge thing in the life of a nurse. But I have found in my own practice that when I do the hourly rounding, the first couple hourly rounds in the morning are tough because you're passing meds and everybody has to go to the bathroom. But once you get past that hump and they see that you're in there every hour, the hourly rounding goes much faster and much smoother, and they don't use the call aids. So it's huge, the benefits that it can have to our practice. And that's it. I just wanted to wrap it up with thank you very much for listening to my presentation. And that's all. Thanks.